Okay, guys. Can you see the PowerPoint? Okay. Okay, thank you, Mohammed. Okay, guys, so these are the objectives. So first of all, otoscopy. Then we have the auditory acuity. This is just like what we did last week when we said the visual acuity and use the Snellen chart. This week, inshallah, we will introduce you to two tests. They're named are Weber and Rennie, and how to interpret them. Okay. So first of all, let's start with the otoscopy. Of course, first of all, any examination that needs an equipment, we have to get acquainted and to know our, equipment. So this is the otoscope, much similar to the fundoscope. Rather, it's much easier. We just have the on and off button here, as you can see. So we press over this red part, and then we rotate it. Then the light would be coming from this piece. Now here we have only the earpiece. Can you see this black part? Now this is, of course, this is disposable. We will use only one for each patient. Okay. So this is a disposable part that you have to connect to the otoscope itself. Okay. Now again, before we start, let's take a basic idea about what we're going to examine. Of course, as you know, the ear is consisting of the external ear. Now the external ear is consistent of the pinna outside, then the external auditory meatus. Okay, so both of these structures, they constitute the external ear. So any disease here or pathology, we will be referring to the external ear. Now here in the middle, of course, we have the middle ear. And finally, we have the inner ear. Of course, the inner ear we cannot examine. Rather, the middle ear, we can examine. The last thing is the tympanic membrane. And the tympanic membrane could give us an indication of some middle ear diseases, infections, or any pathologies. Okay, so the tympanic membrane will be our window to actually examine the middle ear. So basically, we have three structures that we have to comment on, we have to inspect. The first one is the pinna. Then we have the external auditory meatus. And finally, we have the tympanic membrane. So these are the only structures that we can actually visualize with the otoscopic examination. Okay. So let's take a look first at the pinna, which is the external part of the external ear. So first of all, just basic, terms. So we have, this is called the helix. Okay, and this is the anti-helix. Okay, so helix, anti-helix. Then here we have this part, which is called the tragus, and just medial to it is the anti-tragus. Okay, and finally here we have the lobule. And we will not be needing so much, but please remember the tragus because it has some significance in one of the diseases, as we will see later on. Okay. So, guys, what can you see here? This child. Can you see any abnormality? Now we're inspecting the external ear. And of course, this doesn't need, the otoscope. This is done by just inspecting or looking at. Yes, Abdurrahman, thank you. So this is swelling. Thank you, Bushra Hadi. So can you see this swelling? Okay. So clear here, it's red and swollen. Okay. Yes, so the helix is swollen, or we can just say the pinna is red and swollen. Okay. How about this one, guys? Can you see anything? Especially if you look here. What is this area called? What is this process behind the ear? Yes, redness. Yes, thank you, guys. So mastoid. So this is the mastoid bone. Okay. Yes, mastoiditis. If we have other, other features. So from the picture, from the photo, we can say that we have redness over the mastoid process area. And with proper history or maybe with tenderness, we can say this patient has maybe mastoiditis. Now, is mastoiditis connected to the ear problems in any way? If you recall from yesterday's, okay, Fatma. So yes, how? Yes, thank you, Abdurrahman. So yes, thank you, Fatma, again. So sometimes from the middle ear, the infection just goes back through the antrum. It goes to the mastoid process, causing mastoiditis. So actually, mastoiditis is connected to the ear infections and conditions. So actually, if we go back here, so once we inspect, so we inspect first of all the external ear. We look if we have any redness, if we have any swelling, if we have any discharge coming from the external auditory meatus, whether it's just a fluid, whether it's a bloody, whether it's pus. So we'll just look for discharge, and then we will retract the pinna anteriorly and look posteriorly for the mastoid process in case we find any abnormalities like this one. Okay, so it's very simple, the examination of the pinna and external ear. Okay, guys, so this is just by inspection. We look for redness, we look for swelling, we look for discharge, and that's it. And of course, we will introduce the otoscope into the external auditory meatus. Okay, so what should we see? طبعا the external auditory meatus should look like this. Okay, it should be smooth. Of course, we should have blood vessels. Then it should be clean and clear until we see the tympanic membrane at the end. Now, what can we say about this one, guys? Or I think it's written. Anyways, so here, can you see the redness? And there is a bit here of, yes, okay, and the swelling. So can you see it's like congested? Yeah, and if you compare it to this one, look how smooth it is. You can clearly see the tubular structure. While if you compare it to this one, you can see how red it is. Okay, yes, thank you, Bushra. And inflamed. So red, inflamed. Maybe we can see a little bit of bleeding down there, and there is a kind of swelling. Khadija saying dryness. Okay, so you can comment and compare it to the normal auditory meatus. Okay, can you see this, guys? So what is this? I know it's written, but again, yes, thank you. So pus. So can you appreciate this? So this is, first of all, there is a discharge. Any discharge in the external auditory meatus is abnormal. Now, this discharge could be just watery or just like a fluid, clear fluid. It could be pus. Of course, if it's whitish, then most likely this is pus, and of course it indicates inflammation. And sometimes it is bloody, just like what we've seen in this picture. Maybe there is blood. Okay. Okay, how about this one, guys? طبعا this is one of the most common, complaints and the ENT specialty. Can you see how the external auditory meatus is blocked? We cannot see further, and it is impacted. Yes, Abshina, thank you. So this is wax. Okay, so طبعا this is very common, and usually the complaint. Yes, Abdurrahman, it is wax plugged or plugs, or sometimes you can say cerumen. Okay, you can hear this word here and there, but simply this is wax. If you say wax, then this is accepted. The patient usually is complaining of decreased hearing or hearing loss. Yes, Bushra, I agree with you. We should have wax, but it shouldn't be impacted like this. Okay, so this is impacted wax plugs. Okay, so usually the wax should be there, and it's protective, of course, for the ear. But in this case, if it accumulates, then it will cause, of course, conductive hearing loss, and the patient will be complaining of that. Okay, guys. So this is one of the most common presentations. Okay. Now let's take a look at this one. Can you see this? Of course, this is something abnormal. Shouldn't it be cleaned, and that will solve? Okay, Bushra. So let's talk about the wax. Now, if you see, if I go back here, so usually there is something in the ear, in the external ear auditory meatus. It says migration. So actually the cells that start here, they migrate with time and go outside. This is a normal process, and the ear is actually cleaning itself. It usually takes around 6 months for the cells next to the tympanic membrane to migrate and go to the, let's say, to the external part or to the outer side. Now, this process is usually what keeps the ear clean and prevents it from, wax accumulation. But sometimes what happens is there is increased, wax production, or sometimes there are bad habits, like cleaning the ear and uh, not the proper way. So actually, when we use these, earpods, we're actually pushing the wax inside. The more wax it's coming and migrating to the outside, we're pushing it inside. Then we create just like a plug. Okay. Now the plug, sometimes, طبعا the treatment is very simple. Sometimes you can just go to the pharmacy, get the ear drops, and it will dissolve the wax. Or if you want a faster solution, you can just go to the ENT doctor, and then they will directly remove it. Okay. So it's very simple, and it is the most common cause of hearing loss. Okay, conductive hearing loss. Okay, Bushra. So, guys, now let's go back to the abnormalities that we can see in the external auditory meatus. So, can you see this? طبعا, this is very common in the pediatrics age group. So, can you see, first of all, the bleeding? Can you see the destruction of the auditory meatus? Okay, and what can you see here? This is clearly a foreign body. Okay, so please expect, if you have a case about a child and he has the most important and sudden onset of ear pain or hearing loss, then we should suspect that this could be a case of a foreign body. And by the way, foreign bodies, it could be maybe a small part of a toy that the child was playing with. Sometimes it's insects. And if you Google, if you YouTube just insects in the ear canal, you can find amazing documented actually cases about insects being in the auditory canal. Okay. There was also a documented case about a lady. She's young, around 25 years old, and then she has progressive hearing loss. Later on, when they did the examination, they found that she has a bean just like this, a small bean, which has actually grown inside the ear canal. When they took proper history, they found that this lady, when she was a child, she put just a very small bean seed inside her ear, and along these years, this seed has been, growing. Uh, not a tree, but يعني a bean seed, and it has actually grown a little bit. You can search it. It's very nice. If you look for foreign bodies in the ear, you can find all of the weird structures, and you can see like there is one. It's a recorded operation for a patient who has, I think, a living insect. It went inside, and then they removed it. Of course, with an operation. So it's very interesting. Anyways, what we want to consider here is the presence of a foreign body in the ear canal. So if we go back, guys, to the external auditory meatus, this is the normal. And in the exam, we should comment that we don't have any abnormalities. What are the abnormalities? It could be redness and swelling, which may indicate, of course, infection, inflammation, any discharge, okay, whether it's blood, whether it's pus, whether it's fluid. And finally, if we have any wax, any plugs, just occluding the external auditory meatus. And finally, if we have any foreign bodies. Okay, guys, so these are the comments that we want to give over the external auditory meatus. Now, finally, once we're done with that, we will reach the tympanic membrane. Now, the tympanic membrane is the most important structure that we want to focus on. It's of course, as we said, it's our window to the middle ear. So as you can see here, it should be transparent. So sometimes when we, like the previous years and when we used to do it, of course, inshallah, when you come next week, you can do it on each other, the otoscopy. And what we found is that some of us, the tympanic membrane is very transparent, that we can, clearly see all the ossicles of the middle ear. It was so interesting. So usually it should be transparent if it's normal. And we should look for the main structures of the tympanic membrane. So what are they? Can you see this? It's called the cone of light. Okay, طبعا this is not actually a structure, it's a feature of the tympanic membrane. So from where this light is coming, it's coming from the otoscope light that we're using. Okay, so normally we shouldn't see, I mean, normally speaking, anatomically speaking, this shouldn't be there, but actually when we shine a light from the otoscope, usually there is a cone of light. And by the way, it's very interesting that it always points anterior-inferiorly. Okay, so from the cone of light, we can actually know if it's the right ear or the left ear. So this ear should be the right one. So on the right ear, it points towards 5 o'clock. If it's the left ear, it will be pointing towards 7 o'clock. Okay, guys? So from the cone of light, we can decide which side is this. Okay? So the cone of light, it should be present. If it's absent, then this is abnormal, as we will see in a few minutes. Okay. Now the second main structure, طبعا this is called the ambu, and this is called the handle of Meatus. Of course, the Meatus is the first of the three ossicles which are connecting the external ear to the inner ear. Okay, so these three ossicles are connected, and they connect the tympanic membrane all the way through the middle ear, and finally to the window that is connecting to the cochlea. Okay, so the main two structures, guys, are the handle of Meatus and the cone of light, and they should make this angle like this. Okay, now the other structures, we can say that the tympanic membrane has another parts. This is called pars flaccida, and this is called pars tensa. So here it's tense, the tympanic membrane, and here it's a little bit flaccid. Okay, now why are we saying this? Because they say the pars flaccida is sometimes your window to the attic. I don't know if you've taken the anatomy of the middle ear, but usually there is an area just superior to the ossicles. It's called the attic. So this attic, sometimes we have some diseases, just like what we had yesterday, the cholesteatoma. So sometimes the pars flaccida is our window. طبعا, as far as the examination, we want you to comment only on the cone of light and the handle of Meatus. These are the two main structures that we should appreciate in a tympanic membrane. Now let's come and see some abnormalities. So guys, what can you see here? Of course, can we appreciate where is the cone of light, where is the handle of Meatus? No, we can't. And thank you, Sheikha. Yes, we can see a hole, or Russell, thank you. So perforation, okay? So this tympanic membrane is perforated. Clearly there is this hole. Yes, thank you, Fatma. So this is called tympanic membrane perforation, okay? It's very simple. And of course, we cannot appreciate the handle of Meatus nor the cone of light. Pus, Russell is saying if there is pus, no, so maybe this is the one, although it's not pouring in the external auditory meatus, there is no discharge, but maybe it is still in the middle ear. Okay. Now let's take a look at this one. So what can we say about these tympanic membranes? What is this thing up? Okay, you mean this one. Okay. So maybe, yes, thank you. So maybe this is pus. Okay. So this is of course abnormal again. Okay. Or Abdurrahman is saying wax. It could be. And it could be wax, or it could be another type of plug, like maybe pus. But usually if it's pus, it doesn't, get solid. It usually pours and gets like a discharge from the perforation, and usually it's at the floor of the auditory meatus. So most likely, I think I agree with Abdurrahman. Maybe this is pus. Sorry, this is wax, most likely. Okay. And how about here, guys? Let's look at C maybe, or A. It's swollen, yes. What else? Yes, thank you, Rasul. So there is bulging. So guys, the tympanic membrane should actually not be bulged or not be retracted. So if the tympanic membrane is bulging, so what does that mean? So what will this tell you about the condition of the middle ear? So what is causing this bulging? Yes, Hamad, thank you. Increased pressure. So yes, fluid. So this pressure is building up Yes, inflammation or congestion. So simply we have what's called suppurative otitis media. So we have otitis media, and there is inflammatory fluid, which is actually pushing the tympanic membrane. And this is when the patient has pain, okay? Now, if this, if this discharge or this pressure continues to build up, we will end up having this, okay? So the patient will end up having perforation. And this is, by the way, one of the, common scenarios that we have in the exams. So a patient with ear pain, fever, then all of a sudden he tells you, I was just having this pain, then I felt a pop, and then the pain, it, it relieved. So actually this pop was the perforation of the tympanic membrane. So it starts as swelling and bulging of the tympanic membrane because of the accumulation of the fluid. Then finally, the tympanic membrane will perforate, and then the patient will feel relieved because the pressure in the middle ear will be relieved by pouring of the pus outside. And but of course, there will be now a problem of hearing loss. Okay, so the patient will be complaining of hearing loss. Okay, so let's take a look at this one. Who can tell us what can you see? Okay, Abdurrahman, pus, yes, thank you. Anything else? Okay, Nada, thank you. Yellowish, okay. So, guys, first of all, we usually suppurative inflammation. Yes, thank you, Adham. So, first of all, let's comment over the normal structures. So, can we appreciate the handle of Meatus and the conoflight? Can you see them? No, thank you, Fatma. So we cannot see them. So first of all, let's comment. The handle maybe it's this one, but it's actually unclear, okay? So we cannot appreciate the normal features of the tympanic membrane. And actually we have perforation, okay? So yes, thank you also. You said there is pus, but first of all, we have to comment that there is perforation. And from this perforation, you can see a whitish, yellowish discharge, pouring from a perforation in the superior aspect of the tympanic membrane. Okay, most likely this is pus. Of course, if it's put with a proper scenario, then this is most likely a suppurative otitis media with tympanic membrane perforation and pussy discharge. Okay, so this is how we can comment over the tympanic membrane. Okay, guys, how about this one? What can you see here? There is a foreign object. Thank you, Abdurrahman. So what do you think this foreign object is? Foreign body, yes. A ring, okay. Okay. So do you think this is a case of a child maybe who has put something, a foreign body? Okay. So yes, I agree with you. طبعا, you're perfectly right that this is a foreign body, of course. But actually, this is not accidental. Rather than this is a medical foreign body. What do you mean by that? Yes, Russell, I agree with you. Now, yes, this is a foreign body, but at the end, this is actually medically inserted. This is called a grommet tube. And this is actually one of the treatments. Yes, thank you, Adam. So this is perfectly just like what you said. So some patients with suppurative otitis media, what we do is we actually create a hole in the tympanic membrane just to relieve the pressure in the middle ear. And then we insert this tube. It's called the grommet tube. So if you look it up, it's called grommet tube. And then it could relieve and, drain all the pus in the middle ear to the outside. So it will help clean and heal the middle ear. Then later on, of course, it will be removed and the tympanic membrane will be sutured. Okay. Yeah, of course, hearing will be affected. I agree with you, Rasul. But if you compare it to the middle ear, which is full with pus and fluid and infection, of course, this is much better. If you see, it's healed. Look at the tympanic membrane, it looks normal. Even the external auditory meatus, I bet you if we see this patient before putting the grommet tube, it will look like maybe this one. And if we leave it, and it starts like this with bulging behind it, if we leave it, it will rupture. It will eventually rupture. So why don't we actually, uh, yes, so the complications are much worse. So what we do is, instead of waiting for tympanic membrane to rupture, we do the incision ourselves. We insert this tube and we treat it until the middle ear heals. Then this tube will be removed and the tympanic membrane will be sutured. Okay. So Kamil, you're saying that open the eustachian tube as an alternative. Now, guys, the eustachian tube, as you know, it connects the middle ear to the pharynx, to the nasopharynx, and it's one of the most common routes of infection, especially in the pediatrics age group, because it's narrow and small. Yes, it will be obstructed, but actually it's not a route that we can drain the middle ear. Actually, it's a route of ascending infections. So from the pharynx, usually pathogens, they go to the middle ear. That's why they say when you sneeze or cough, don't block your nose because the pressure will build up and it will go back to the middle ear. And this is usually very common in the pediatrics because the canal will be very short and infections will easily go that way. But it's not, let's say, a way of draining the middle ear. So the middle ear, if it's if it's congested with fluid, it's much easier for us to insert a grommet tube rather than doing, like, how can we open the eustachian tube? It has to be a major surgery. Okay, so this one actually it's much easier than doing a nasopharynx surgery than trying to dilate maybe the eustachian tube. Okay, and if we do that, by the way, this will be a permanent route for infections, for introducing infections to the middle ear. So this is what we do. It's very simple, and by the way, repairing of the tympanic membrane is easy, and it could be done. It's not a major operation. Okay, so it could be done easily. So they do an incision, insert the tube, wait for maybe a few weeks for the middle ear to heal. Once it heals, then they will remove this tube and suture the tympanic membrane. Okay. So I know the discussion could take long here because it's very interesting, but actually this is the basic ideas that we need to comment in the ear examination. So if we go back and look at the main three parts that we said about. So we inspect, first of all, the external ear, which is the pinna, of course. We look for redness, swelling. We retract it anteriorly, and we look for the mastoid process behind it. Look for any posterior, spread of a middle ear infection. Then we introduce our scope and look at the external auditory meatus, and then we look for any discharge, any redness, any swelling, any foreign body, any wax. Then we introduce more our otoscope. Then we look at the tympanic membrane itself. We look at the cone of light. We look at the handle of Meatus. Of course, this is the malleus bone. Okay, and this is how it's connecting the tympanic membrane, transmitting the sound waves all the way to the cochlea. Okay, and then from the cochlea, of course, we have the 8th cranial nerve. Now, then, of course, we look at the tympanic membrane. We mention the normal features, the handle of Meatus, the cone of light. Then we say that we have no perforation, no discharge, no bulging or retraction. So yes, or foreign bodies. So these are the main points that we will comment on. It's very easy, very simple. One of the easiest examinations that we could have, of course, in this semester. Okay, guys. So any question? Of course, we will watch a video later on. Don't worry about that. So this is just the theoretical part. We will watch a video, then we will demonstrate it in a few minutes in the lab, inshallah. Okay, and inshallah next week you will be practicing this. Now, the next objective of our session is the auditory acuity. So what do you mean by this? Have you heard about Weber and Rennie tests? I think they were introduced yesterday in the case, and they worth that we should mention them and actually know how to interpret them. Now, guys, even not only in the session, but if you go back to your cranial nerves examination checklist, you can see that in the area of the 8th cranial nerve, we have the whispering test that we did earlier, and we have these two tests, Weber and Rennie. So anyone can tell us what are these tests? So let's start with Weber. Or guys, before that, let's take this basic information. So usually our apparatus, which is the ear, is designed in a way that air conduction should be better than bone conduction. Okay, so if the sound is traveling through the air, so it should be louder and better than if it's traveling through the bone. Okay, because if it's traveling through the bone, through the air, it will, immediately go to the tympanic membrane, and then from tympanic membrane to the ossicles, then to the inner ear and to the 8th cranial nerve. Okay, so this is the rule that air conduction is better than bone conduction. This is normally. So we have two tests to examine the auditory acuity. And when we do these two tests, we're looking for two main types of hearing loss, whether it's conductive hearing loss or whether it's sensory neural. So guys, what do you mean by conductive hearing loss? Any idea? So what is the difference between conductive hearing loss and sensory neural hearing loss? There is an obstruction, yes. Thank you, Abdurrahman. Any other suggestions? Are not being conducted to produce sound in the ear components. Yes, thank you, Muhammad. This is well said. So, guys, simply, the ear works in a very simple way. So the pinna actually, it accumulates the sound waves, then it takes them through the external auditory meatus, then to the tympanic membrane, through the ossicles in the middle ear, then to the cochlea, then from the cochlea to the vestibular nerve or vestibulocochlear nerve. So if there is any abnormality, anything that prevents the sound waves to be conducted to the cochlea, then this is called a conductive hearing loss. So just name it. So look at the external auditory meatus. If it's blocked with wax, with foreign body, with discharge, look at the tympanic membrane. If it's perforated, if it's sclerosed, if it's bulging, look at the middle ear. If there is any pus, any discharge, any abnormalities with the ossicles, if there is any problem in the start of the inner ear, anything that prevents the sound waves to reach the cochlea, this will be called conductive. So from the names, it's conduction. So conduction of sound starts from the pinna and down to the cochlea. Now sensory neural, from the name, it starts with the 8th cranial nerve. So any pathology affecting the 8th cranial nerve and the higher function, so the brain. Okay, so we can start, maybe there is a famous case of schwannoma or 8th cranial nerve, let's say tumors. Then name any pathology in the central nervous system, stroke, meningitis, encephalitis. Okay, so any condition that affects either the 8th cranial nerve or its central centers, it is called sensory neural. Okay, so sensory neural in comparison to conductive. So in conductive hearing loss, we have blockage of the pathway, and sensory neural, this is usually a higher centers problem, rather than either the nerve or the brain itself. Okay, guys, so this is the basic two types of hearing loss. So our job now is to do the Weber and Rennie tests and say if this hearing loss is conductive or sensory neural. Okay, so how can we do that? So let's take first Weber test. So Weber test, طبعا we use the tuning fork, and guys, we use 512. I will show you that in a few minutes in the lab, inshallah. Then we tap it, then we put it over midline, bony process. Okay, so guys, what do you think the normal individual should hear in Weber test? So we will tap the tuning fork, we will put it on a midline process. Okay, Mohammed, so thank you. So both sides should be the same. Okay, yes, Abdurrahman, from both ears. So simply the normal Weber test, we should say there is no lateralization. Okay, the vibration is coming from the middle. Okay, thank you, Dima. But this is not vibration, hearing. Okay, that's why I emphasized on saying this is 512 hertz, tuning fork. And vibration sense, if you remember, guys, what we did when we tested the vibration bil upper and lower limbs, we used 128 hertz. And inshallah, when you come to the labs, I would advise you just to tap the two forks and feel it. So the 128 hertz will give you a strong vibration sensation, while the 512, it will not give you vibration, rather you will hear. Okay, so again, this is a hearing test. Good. So what you're saying, guys, is when we tap the tuning fork and we put it, for example, over the forehead, the patient should be able to hear both sides and the same intensity and the same acuity, and there should be no lateralization. Okay, so there should be no lateralization. So if you want to say Weber test is normal, then you say there is no lateralization. So it means there is no one side better than the other. Now, how about Rennie test, guys? So how can we interpret Rennie test? Rennie test, now the interpretation is actually sometimes it's a bit confusing. And if you remember that from yesterday's case, Rennie's test, Awalshi, how do we do Rennie? What is the idea behind Rennie test? Conductive timing of air should be 2 times longer than that of bone. Okay, thank you, Abdurrahman. So air conduction should be better than bone conduction, as we said. So any idea how, guys, how do we perform? So the Weber is easy. We tap it, we put it on the midline structure. How about the Rennie test? How can we do it? This is the Rennie test here on the side. Okay, yes, thank you, Abdurrahman. So yes, simply, so we will tap the tuning fork, then, okay, put it on the mastoid, stops hearing. Yes, thank you, Jasim. So guys, what we do is we tap the tuning fork, then we put it over the mastoid process, okay? Then we ask the patient, can you hear this? Of course, the patient will be able to hear that. Now, this is called bone conduction, okay? So can you see this one? So first of all, we test bone conduction, sorry. Then what we do is we tell the patient, okay, sir, when you stop hearing the sound, please tell me. So the tuning fork will start slowing and vibration. Then the patient will tell you, I stopped hearing that. Then we will take the fork from the mastoid process, then we will project it just next to the patient's ear. Now, what we're testing is the air conduction, okay? And since we said that air conduction is better than bone conduction, the patient should still be hearing this. So he stopped hearing from the bone conduction, but if we project the, the tuning fork, he should be able to hear air conduction, let's say on a lower, amplitude, okay, or loudness, okay, and this is normal. So put it on the bone first, on the mastoid process, tap it, then the patient will be able to hear that. Once it stops, we take the tuning fork and we put it next to the patient's ear. Then the patient normally should be able to hear that. Okay, so this means that air conduction is better than bone conduction. So this is the normal. And if Rennie test is normal, we say it's positive. And this is where it gets a little bit confusing, guys. So the normal Rennie test is labeled as positive. Okay, and this might confuse us a little bit because usually when we say the sign is positive, we mean that it's abnormal. But this is not the case in Rennie test, because if we say it's negative, then it means that it's abnormal. So if we say it's positive, meaning that air conduction is better than bone conduction, which is, of course, the normal case here. So do we know, guys, how do we comment on Weber and Rennie? So Weber, normal, no lateralization, and normal Rennie is positive. So let's take some cases and then we will be able to further interpret these tests. So I've done this, basic scheme. So this is a patient with the right ear, the left ear, and we will do both Rennie tests and Weber tests for this patient. So who can tell us, guys, what is this? Who can interpret this for us? Okay, so Nada, thank you. You're saying this is normal. So patient has no issues. Okay, thank you. So first of all, Weber, there is no lateralization. Okay, so the right and the left, the patient can hear equal, sound if we place the in the middle. Yes, thank you, Adam. Now, if we go to the Rennie test, we see that both of them are positive, meaning that air conduction is better than bone conduction on the left side and on the right side. And of course, this patient would be a normal patient. Okay, thank you. So let's see another example. Okay, now let's take, guys, Weber first. Now, if Weber lateralizes to the right, what does that mean? What do you think this case is? Problem in the right ear. Okay, so if Weber lateralizes to one side, what does this mean? It has two interpretations. It's either or. Okay, thank you, Jason. So Jason is saying this is conductive on the right side. But if forget about Rennie, let's say that we only did Weber and it lateralizes to the right side. What does that indicate? We have two options, guys. Now, what does it mean when we say lateralizes to the right? What does that mean? It means that the patient is hearing the sound louder on the right side. So, okay. So when we say Weber lateralizes to one side, meaning that this patient is hearing the sound from the tuning fork in the middle more on the right side. So what could this tell us? Now, Weber test has two interpretations. Either the same side that it has lateralized to has conductive hearing loss. Okay? Yes, thank you, Josem. Or actually the other side has sensory neural hearing loss. Now, how can we understand this? So if the right side, let's say, or the same side where Weber lateralizes, there is conductive hearing loss, it means that the sound will travel through the bone and it will look louder for the patient, okay, on this side. Or actually, the other side has a problem in the nerves, so it's not hearing aslan, okay? It's not hearing either from the bone or from the air, okay? So the patient will hear better on the normal side would be, and the other side will be having a sensory neural. So just to put it in order, when Weber lateralizes to one side, either that side has conductive hearing loss or the other side has sensory neural hearing loss. Okay, now who could tell us which one is which? It's by doing the Rennie test. So Rennie test on the left side was positive, meaning that the left side is normal. So the hearing, sorry guys, the Rennie test will tell us either this patient has conductive hearing loss or doesn't have conductive hearing loss. Now, how about the right side? What could Rennie tell us? Now, Rennie is negative, meaning that here bone conduction is better than air conduction on the right side. So how can we interpret this? So from Rennie itself, what do we have on the right side? Yes. Okay. So thank you, Justin. So from the Rennie test, we can say the right side has conductive hearing loss, right? Because it's negative. So Rennie test will tell us either there is conductive hearing loss or there isn't. Okay. Now, when we combine it with Weber, we said Weber lateralized to the right. So either the right side has conductive hearing loss or the left side has sensory neural. So actually, Rennie here on the right side confirms that the right side has conductive hearing loss, and Weber lateralizes to the right, so they go together, and this case is a case of right conductive hearing loss. Okay, guys, I hope it's clear, but inshallah with more examples it will be much clearer. Okay, guys, who can tell us what is this case? Or maybe what is your diagnosis for this patient? So Weber lateralizes to the right again, but both readings are positive. Okay, Muhammad, how do we confirm if it's sensory neural? We cannot actually. And we have only Weber tests that we can say it could be. But in order to confirm if this is sensory neural, we have to do other tests. Okay, so maybe we will do some imaging, some MRIs, some other hearing tests, more advanced, I mean. Okay, but from the Weber and Rennie, this is what we can do. Okay. Yes, audiometry, maybe. Okay. So, I mean, we could do further testing if we want to, like if we're suspecting that this is really a sensory neural hearing loss. Okay. But simply what we want to do here is to interpret Weber and Rennie. So guys, I think some of you wrote left-sided sensory neural. So let's analyze this. Now Weber lateralizes to the right. So either the right side has conductive hearing loss or the left side has sensory neural. But if we look at Weber, we can find that it's positive on both sides. So on both sides, I do not have conductive hearing loss. So if we go back to Weber, either the right side has conductive, it was proven not to be the case because Rennie is positive. So we're left with the other option. So the left side has actually sensory neural hearing loss. Now, although you can see Rennie is positive, but Rennie, it doesn't say anything about the sensory neural. Rennie is only tell us if there is conductive hearing loss or there isn't conductive hearing loss. And guys, notice that if it has sensory neural hearing loss, still the air conduction is better than the bone conduction, but it hears for a lower, acuity. فاهمين الفكرة? So instead of hearing, طبعا hearing it has an amplitude. It's measured in decibels. Okay. So usually, let's say we should hear up to or down to 10 decibels. And if patients start to have sensory neural hearing loss, it means they're not hearing the low intensity voices. Okay, but still the air conduction is better than bone conduction. That's why Rennie is testing positive on both sides. Okay, but Weber actually it's lateralizing to the right because the patient is hearing better on the right because this is normal and this is actually affected with a sensory neural hearing loss. Okay, I know it's a bit complicated, but and if we simplify it, it's very easy. So first look at Weber. When it goes to one side, then either this side has conductive or the other side has sensory neural. Which one will confirm it? Rennie will confirm it.